All right, let's get right into this. Welcome back, everyone. Today's explainer is essentially your ultimate investigator's playbook for mastering some of the most complex respiratory coding guidelines out there. We're tackling part 5 of our series, focusing strictly on COPD and asthma coding mastery, and we are drawing this straight from official chapter-specific guidelines and AHA coding clinic directives. If you're a medical coder, a CDI specialist, or an auditor, you already know that respiratory charts can be, well, they can be incredibly tricky mysteries to solve. It's like a giant puzzle sometimes. But today, we're going to break down the exact logic and clues you need to code these conditions with total confidence and compliance. So here's our game plan for today. First, we'll look at exacerbation versus infection. Second, cracking category J44. Third, cracking category J45. Then we'll head into the clinical interrogation room for 2 real-world case files, an asthma overlap and the triple threat, right before we wrap up with our final verdict and next steps. Okay, let's start with our first topic, exacerbation versus superimposed infection. Before we can even think about assigning a code, we have to establish the primary rule of law when dealing with chronic respiratory conditions like COPD and asthma.
According to the official chapter-specific guidelines, the codes in these categories distinguish between uncomplicated cases and those in acute exacerbation. And the guidelines are highly specific here. An acute exacerbation is defined exactly as a worsening or a decompensation of a chronic condition. The absolute key word to lock onto here is decompensation. It is fundamentally an internal worsening of the patient's baseline state.
Now, you've got to draw a clear line in the sand with this next point. The guidelines explicitly state that an acute exacerbation is absolutely not equivalent to an infection superimposed on a chronic condition. Yes, an exacerbation might be triggered by an infection, that happens all the time, but they are not the same thing in the eyes of ICD-10-CM. A trigger is just a trigger. This distinction is literally the bedrock of accurate respiratory coding. Right. Let's move on to cracking category J44 for COPD. Let's see how that primary rule we just talked about helps us as we investigate our first suspect lineup for chronic obstructive pulmonary disease. So ICD-10-CM uses combination codes to create highly specific classifications. When we look at the J44 family, we see codes built for very specific severities and situations. Notice how the system separates them out. We've got J44.0 for a lower respiratory infection, which is distinct from J44.1 for an acute exacerbation. Then we have specific codes for things like bronchiolitis obliterans and other specified COPD, all the way down to our fallback, which is J44.9 for unspecified. Your job as a coder is to scan that clinical documentation to find exactly which of these clues is driving the patient's encounter.
Now let's shift gears and jump into category J45. We're going to dissect exactly how we classify asthma. Category J45 basically operates on an escalating clinical ladder of severity and frequency. Think of it as stepping up the rungs. We start at J45.2, mild intermittent, and step up to J45.3, mild persistent. As the clinical picture worsens, we climb up to moderate persistent, all the way to the top rung, severe persistent asthma. Each one of these steps requires really precise documentation from the provider detailing just how frequent and severe the patient's symptoms are.
But you know as well as I do, we don't always get that perfect level of detail from providers. That's where category J45.9 comes in as our fallback. It catches all those other and unspecified asthma diagnoses when the medical record just completely lacks the severity details necessary to climb that clinical ladder we just looked at.
All right, we have the theory down. Now let's put these official guidelines to the test on a real-world clinical scenario straight from the Knowledge Corner. Let's open our first case file, asthma overlap.
Picture this in a chart. You're reading the encounter and it says, 45-year-old male presenting for follow-up of COPD and diagnosed with asthma unspecified. Now look closely at those 2 diagnoses side by side. How did you code this specific combination? Take a second, run it through your head before I reveal the logic.
Okay, here's how combination codes work their magic here. Based on AHA coding clinic guidance, this was from Q2 of 2024 by the way, step 1 is identifying the overlap between COPD and asthma.
Step 2 is assigning the combination code J44.89 for other specified COPD. But look at Step 3. This right here is the trap coders fall into all the time. You absolutely must omit a separate unspecified asthma code. Why? Well, because the inclusion and exclusion notes dictate that J44.89 already encompasses this overlap. It explicitly forbids assigning that extra unspecified asthma code. The combination code does all the heavy lifting for both conditions.
Awesome. Let's level up a bit. Case file 2, the triple threat. This one proves that things aren't always what they seem on the surface of a chart.
So here is the documentation. 36-year-old male with cough/wheezing presenting with COPD, emphysema, and moderate persistent asthma. When you see these three heavy-hitting respiratory diagnoses documented together in one sentence, where should your eyes immediately go in the codebook?
Going back to that same AHA coding clinic guidance, here is the exact logic. Step 1. You identified the emphysema, assigning code J43.9, and the moderate persistent asthma, assigning J45.40. But Step 2 is the real clinical game changer. You have to recognize that emphysema is inherently a form of COPD. Because of that inherent, built-in link, Step 3 tells us to omit J44.9 for unspecified COPD entirely. Actually, it's flat-out inappropriate to assign an unspecified COPD code in addition to the emphysema code, unless the COPD is further specified as having an infection or an acute exacerbation.
Pretty eye-opening, right? All right, let's transition to our verdict and next steps. We've covered a ton of ground today, navigating from foundational definitions straight through to applying HHA coding clinic logic to actual case files. Let's lock in those high-yield facts.
So here's your final verdict. Keep these in your back pocket whenever you're auditing a respiratory chart. Number 1, an acute exacerbation is strictly a decompensation or internal worsening of the condition, not just a superimposed infection. Number 2, categories J44 and J45 are specifically built to distinguish between uncomplicated cases and those experiencing that exacerbation. And number 3, always remember this one. Emphysema inherently includes COPD. If both are documented, you code the emphysema and omit that unspecified COPD code. Mastering these little nuances is exactly what ensures compliance and bulletproof accuracy in your coding practice.
So as you look at your very next chart today, ask yourself, is the documentation telling the true clinical story, or is it leaving you stuck on that unspecified fallback? We're going to dive even deeper into this whole world in our next explainer. Coming up next is part 6, where we will tackle emphysema, bronchitis, and pneumonia clinical scenarios. Trust me, you won't want to miss it. Until then, decode healthcare with Harshal.